Hello, so this talk is about Lyme disease or borreliosis and the essentials towards diagnosis. And my name is Dr. Husain. So learning is not filling a vessel but sparking a flame, according to Socrates. And I'm taking a similar sort of approach with this talk. It will not give you all the answers, but hopefully it'll give you an overview and also spark some thoughts in you and give you some information about where else to seek information. So first of all, what is Lyme disease? What is borreliosis? So Borrelia is a class of bacteria from the spirochete family. It can be a multi-system infection. So it can present in a multitude of ways, including affecting the nervous system, joints, the heart. It is known as the new great imitator because it can present in so many ways and mimic so many other conditions. You may be aware the original great imitator is syphilis, which is also a spirochete. And this talk will focus on clinical identification of Lyme disease or borreliosis and give you an overview of the infection itself. So first of all, common question is why the variety of presentations? And once you look into infections in general, you'll realize actually this is quite a common phenomena. It is understood a bit more and more widely understood in the current age. But if you look, for example, at polio, a lot of people equate that with paralysis. But when you look at the data, you find actually that's not completely the full story. The vast majority of people, about 90 to 95% who contract polio, are either completely asymptomatic or have a minor non-neurological illness like a bit of sore throat or gastroenteritis. It's only about 5% who have neurological symptoms, be they non-paralytic or paralytic, and then only about 1% are left with paralysis, which may or may not get better over time. And there is some evidence that physical activity and IM injections during the prodrome phase of polio can be exacerbating factors for paralytic disease. So there's arguments for rest during the initial phases of illness. And in terms of numbers, it's similar to other infections like measles or TB. So any presentation of disease is dependent on host, infection, and environment factors. So with the host, their genetics, their nutritional status at the time of becoming unwell, their own immunology, and how, for example, run down or tired they were at the time of being ill, the infection, which branch of the bug, the virulence, and so on and so forth. The other common thought is, well, this seems to be a rather recent thing, haven't heard about it before, and if you were to delve into the historical medical literature, you'll find there is a long and extensive history of Lyme disease, though it's frequently known by different names. To make a long story short, somewhere between the 19th century and mid-20th century literature based in Europe, there are descriptions of various clinical entities, be it of the skin or neurological manifestations, and they go by various different names, like Banworth syndrome, for example. Then there came a point where these clinical entities were associated with tick bites. At some point in the 1920s, there was a suspicion of an infective agent. In the 1930s, there was a debate whether it was a tick toxin or an infectious agent the ticks were carrying. And then in the 1950s, there were some very interesting experiments where they demonstrated the infectivity of Erythema migrans and improvement with antibiotics. Looking at the US literature, in the early 20th century, it was generally a disease that was recognized in recent European migrants. Then it seemed to have been forgotten for a couple of decades until the 1970s, where there was an outbreak of pediatric arthritis in a place called Old Lyme in Connecticut, USA. And initially it was put down to some rheumatological problem, and then local mums in the area were like, well, why are we having this rare diagnosis so widespread in this relatively small area? There must be something more to this. They pressed the local medical team. It also so happened that there was a European doctor working there at the time who recognized the Erythema migrans rash and related it to old European literature, so the connection was made. And then there was some really interesting research that was done that made the connection with the ticks in the local site, the the local countryside, and then these illnesses, and it was subsequently named Lyme disease after the area, even though it had a long extensive history prior to that. And they also in the early 80s managed to isolate the spirochete, which was causing the problem. And then talking of spirochetes, this is the spirochetal family tree. Up here you have syphilis, over here you have Borrelia, and then looking more specifically at Borrelia, the multiple different branches of the infection which can contribute towards the clinical entity that is known as Lyme disease or borreliosis. And this is Borrelia burgdorferi, which is often tested for. And then moving on to the life cycle of the tick, which carries the infection. This is just a slide to say that there is a life cycle, and it likes to feed on multiple different mammals of different sizes, and depending on the life cycle, it can come in different sizes. And in terms of transmission, it's kind of frequently put out there that there needs to be a minimum of 24 hours before getting the infection. The reality is there is no minimum proven time for transmission of the infection from an infected bite. Ticks are also dirty, they can carry more than one infection, and bites are often unnoticed, partly due to the size of the ticks and partly because they inject a local anaesthetic before they do their thing. So how can it present? Generally, you might find a person is presenting with out-of-season flu-like symptoms, labelled as summer flu. They may have non-specific symptoms of just feeling generally unwell. They may or may not remember a tick bite, and they might have the Erythema migrans rash. Happens in about 2/3 of Lyme disease cases. If it's present, it's diagnostic, it's pathognomonic, treat. Or they may be presenting with a feature of disseminated disease or late disease. So they might be presenting with facial palsy or pericarditis or myocarditis or with a swollen joint. So 3 stages: early, early disseminated, and late disseminated. Early is generally in the first month of infection. If they have Erythema migrans, it's possibly localized to the area of the original bite. They might be presenting with non-specific symptoms like lethargy, malaise, anorexia, headache, cough, sore throat, fever, abdo pain, arthralgia, neck stiffness, cognitive impairment, lymphadenopathy, myalgia, weight loss, and so forth and so on. When it comes to early disseminated disease, that is generally around the 1 to 4 month point of infection. They may have disseminated Erythema migrans, which is distant to the original bite, and it's multiple in number. They may have organ involvement at that point, and common areas affected include the skin, neurological system, heart, joints and eyes, but it can affect other areas too, and indeed there's histological evidence of other areas being affected. In late disseminated disease, this can occur years after the initial infected bite. So Erythema migrans, we know about 2/3 of patients may present with it or may have Erythema migrans. Reiterating, if it's present, it's diagnostic, treat. But if it's not present, it doesn't rule out disease. It has a multitude of appearances. It can usually, about 80% of the time, 70 to 80, it's a uniform red expanding rash, but it can also have a bluish hue, may or may not have central clearing. It could be oval shaped, it might be purplish, it might even be a triangular or linear shape. The bullseye rash, which is pretty famous, occurs only about 20 to 30% of the time of Erythema migrans rashes. And to complicate matters, in people with darker skin tones, it may not appear as red at all. It might just be a deepening of their skin colour. It might be brownish, or there might be a subtle erythema. And then to make things even more difficult, cameras lack diagnostic colour accuracy. So what that means in real terms, particularly for people with melanated skin tones, it can tone down any redness or erythema that is there and visible to the naked eye. So one way of counteracting that, because we are doing a bit more telemedicine than we used to, is if you're seeing a picture of a rash and you're not seeing the redness or the pinkness, and the patient is mentioning they have this rash, ask them, to the naked eye? Is there redness or pinkness that they can see that isn't coming through on the camera? Other features, it may have a central crust, and it may be a heat sensitive rash. So they might be telling you it only appears after they have a nice hot shower, and then, you know, about half an hour it just disappears completely. And if they've got multiple lesions, there is a strong possibility it is disseminated disease. Now we're going to see lots and lots of different photographs of erythema migrans. This is an example of the bullseye rash. But if you kind of head back to the literature, particularly the initial literature done in the 1970s around Lyme, they depict multiple different appearances of the erythema migrans rash. And it's uniform, it's bullseye, it's purplish, it's got central crusting, it comes in different sizes. So while a lot of the time it's 5 centimeters or more, sometimes it can be a lot less than that. Patients have described it as being hot to touch. Some describe it as burning or itching or painful, or for some people it's asymptomatic. Here are some more pictures. The purplish hue, possibly a bit of central crusting. Here there's that pinkish colour. Here you've got slight central clearing. You've got the oval shape. Here you've got a triangular shape. Here you've got multiple different examples of different shapes. Here's an example in melanated skin, deepening of the skin tone, not obviously more red, so just bear in mind it can be not so obvious, possibly some central clearing to be seen there. Here's another example. To the eye of faith, you can say it's a slightly warmer skin tone, maybe erythematous, compared to their underlying skin tone. And here's another example, and the purplish skin tone on this side. So varied appearance. And another example where there's a deepening of their skin tone and some slight redness. Another different skin manifestation is borrelial lymphocytoma, and this can affect the ears, the nipples, the scrotum, the lips, and it's generally a soft, doughy lump or firm nodule. It can range from being the normal skin colour to having reddish brown or reddish purplish areas. And, you know, this is a more dramatic example. And on histology, it's found to be some density of lymphocytes, and again, some swelling here. And then the other skin manifestation is acrodermatitis chronica atrofans, and this is generally in late disseminated disease where there can be violet plaques, often on the extensor surfaces. It could be painful, inflamed, fibrosis. On histology, there's loss of structures like the sweat glands and hair follicles. There may be atrophy of skin, and it's often described as being of tissue paper thinness, and there can sometimes be chronic and difficult to treat ulcers. When it affects the joints and vessels, there might be effusions or transient migratory effusions. It can affect the tendons too with pain. When there's a vasculitis, retinal vasculitis has been described with visual loss, and cerebral vasculitis presenting in different ways like stroke or aneurysms or infarcts. And this is another example of an effusion in Lyme arthritis. When it affects the nerves, it's known as neuroborreliosis, and again, it can present in a multitude of ways. There can be facial palsies, cranial nerve deficits, encephalitis, meningitis, myelitis, radiculitis. There can be loss of balance, of proprioception, and it may even mimic symptoms of other conditions like motor neuron disease, Guillain-Barré. And then there's Lyme Carditis. Again, common theme. Variety of presentations. There can be multiple different types of arrhythmias, varying from AV conduction disorders to heart blocks to prolonged QTC, or there could be, for example, a pericarditis or myocarditis or a mixed picture that isn't presenting in the usual way a viral type would, and there have been deaths, and it's frequently been a posthumous diagnosis. There's debate in the literature about prevalence. It's generally put somewhere between 1 to 16%. And again, debate in the literature. Is it rare, or is it actually underreported and under-recognised, and possibly an unrecognised cause of sudden death? And then talking about cases where there have been case series done on postmortems, it's generally been on organ donors. Sometimes it's been suspected while they're alive, but sometimes it wasn't. And one particular case series from the States, the pathologist in Atlanta who was doing the post-mortem noticed that the case of myocarditis he was looking at wasn't typical in appearance for the usual viral myocarditis, and he'd worked previously in New York in a Lyme endemic area and recognized some features that could be in keeping with Lyme carditis. He tested that assumption, did the specific staining, the specific tests, and found that indeed that particular organ donor had died of Lyme carditis. They then went and tested some other cases, and they then revealed that there were other cases of Lyme carditis too. Now these photographs, the point of that story was that if that particular pathologist hadn't had that suspicion, hadn't had that knowledge, those cases could have been lost and just put down to an atypical appearing viral myocarditis. So this young man here, his name is Joseph Alone, and he was a 17-year-old young man who was very bright and had a promising future, was hoping to go to Brown University, and he was doing some field work in some forestry areas, and then became unwell. And he went with his parents to the pediatrician, and it was thought to be just a really nasty case of flu. He was sent on his way. The following week, he was still unwell, returned to the pediatrician. They ran some blood tests to check for whether there may be a different cause. By the third week, he collapsed in his mother's front garden, and then was taken to hospital, and was found to have a heart problem, and unfortunately ultimately died. He had a post-mortem done and was found to have disseminated Lyme disease in multiple organs, and also to have Powassan virus, which is another tick-borne infection. Now, the points I want to kind of pick out of this case, one is that ticks are dirty, they can carry more than one infection, and two, a person can have widespread Lyme borreliosis in multiple organs, and they may not have the Erythema migrans rash. He didn't have the rash, and when the test did come through, it was negative. So you can test negative, have widespread disease, and die. And this picture here is of Dr. Neil Spector. He was a research oncologist in Duke University in the States, and he picked up Lyme disease and ultimately developed Lyme carditis, and he over years eventually developed quite severe heart failure requiring a heart transplant. Now he's written quite extensively and given interviews and talks about Lyme disease, which are quite interesting to listen to, and he's also documented his journey in this book, Gone in a Heartbeat, which is quite sentimentally written. But one of the frustrations he mentions is that the rigor in the scientific research that he's used to in the oncology space was lacking somewhat in the Lyme disease research space. So, moving on. When can it happen? It can present throughout the year. The peaks are generally with early disease, spring to early autumn, and disseminated disease between June to December. Now this data is from the CDC. It doesn't differentiate between early and disseminated disease, but what you can see is that it does present throughout the year, though there is a peak in summer and early autumn. Now this data is from the UK, from GP records, and it's data from about a decade ago, but you can see here that 50% of cases present in the summer, but the remaining 50% present throughout the rest of the year. And again, from the Cairns study of GP records, where can it happen in the UK? Well, there's Scotland, but also it's presenting throughout England and in Wales and in other areas too. So we know it's throughout the UK. So, testing. Now, when we test for Lyme disease, what we're testing for are the antibody response to Borrelia burgdorferi. The test is not a direct test, it is not a culture, it is totally dependent on the antibody response to the infection. So it's an indirect test. It can take a variable amount of time for the antibodies to develop, from weeks to months. So that's why it's often said that testing in early disease may not be reliable, but also why the test cannot rule out disease. Now, the antibodies may not develop at all if they've taken steroids or they're immunosuppressed. There's some interesting research in the microbiology and clinical literature where Borrelia has a evasive quality when it comes to the immune system. It's part of how it disseminates. It can evade the immune system. So there's the possibility that a person who's very ill with disseminated disease may not mount an immune response, or may mount a very weak immune response, antibody response, as a result of the infection. So it may not be picked up with formal testing. And the other thing to bear in mind, it's a narrow test. It doesn't test for all the other tick-borne diseases and co-infections. So as GPs, when should we suspect it? A couple of things. If you've got a fit, well, active patient who normally never attends a GP surgery, and they're coming to you and they're ill, they're not getting better, and it's not clear what's going on, have it in your differential. If there's multi-system involvement, consider it in your differential. If they've had outdoor exposure through spring to autumn, another reason to have it on your differential. And bear in mind, they may not volunteer that information to you. You know, they might be presenting, for example, with a facial palsy or pericarditis, but they might not say to you, oh, by the way, I was going for walks in the South Downs, or I was camping in Scotland and had a bite. So you have to specifically ask for that information. If they've got erythema migrans, you've got the diagnosis. If you've got a patient, it's not clear what's going on, they're deteriorating, they're developing new symptoms, there comes a point where watchful waiting is no longer appropriate. And you've got to be thinking about other alternative diagnoses, and this is a time to include it in your differential. How can we treat it? The NICE guidance is very good. Look at the NICE guidance. These aren't the sort of doses you can remember off the top of your head. They can be higher and for longer durations, generally for 3 weeks or longer. And the type of dose and type of antibiotic and duration depends on the stage, the systems affected, and the age of the patient. There's a variety of different antibiotics that are recommended, and you're advised to consider a second course of an alternative antibiotic if they have ongoing symptoms, and also to seek specialist advice. A word about the Erythema reaction. This is a worsening of symptoms within the first 2 to 3 days of starting antibiotics. This could include high fevers, feeling lightheaded, and onwards. This is thought to be due to a release of cytokines due to the mass kill-off of bacteria. This doesn't happen in all patients, and generally it's supportive management and continue with the antibiotics. So coming back again, key points from the NICE guidance. If you've got the erythema migrans rash, you've got the diagnosis, treat without testing. If it's absent, but there's clinical suspicion, consider starting antibiotics while you're doing the test. The test has limitations and cannot be used to rule out disease, particularly when you've got significant clinical suspicion. Try to review the patients within a few weeks to see how they're doing. Be mindful of the Erythema reaction. Consider a second course of antibiotics if they're not getting better. And be mindful that disseminated disease has different antibiotic recommendations and durations than early disease. Refer to the NICE guidance. And infection does not provide any immunity. They can get infected again. So there'll be some people who'll say, well, erythema migrans can disappear on its own. What happens if we don't treat it? Well, it's the same logic as not treating the initial skin manifestations of syphilis. It's a bad idea. Both the initial skin manifestations of syphilis and erythema migrans are a possible harbinger of what is to come. They might be okay, months, maybe even years in between, but the infection is doing its thing. You treat when you see it. Steroids. Exercise caution. It can lead to poorer outcomes if there's underlying active infection present. If it's used, it can lead to false negative Lyme serology. Diagnosis. A word about it. It does matter. If a patient gets a diagnosis, they stand in line ready to receive appropriate treatment. They can receive appropriate support and rehab and the wider support the society gives for those who are ill, and they have a chance at recovery. Now, when patients are ill and they don't have a diagnosis. They are stranded in a no man's land of the medical wilderness. Now, there's a nice definition for no man's land in that it's a land that's unoccupied or is under dispute between parties who leave it unoccupied due to fear or uncertainty. And that's quite a good description of what can happen to some patients when it's not clear what's going on, but people are a bit too afraid to put a definitive diagnosis, and then they just end up stuck in this place. It's okay to have a working diagnosis. It's okay to hold that diagnosis lightly, and it's okay to change that working diagnosis when new information comes to light. That's how we work as doctors. If a patient doesn't have a diagnosis, they're at risk of preventable deterioration, preventable morbidity, and potentially mortality too. Diagnosis matters. What we do matters. So what else can we do? If you see a tick bite, if you see erythema migrans, code it, record it in the notes, even if you've treated it at the time. If they become unwell months, years after the initial bite with disseminated disease, it can provide a trail of evidence that can help form a diagnosis. Prevention. Ultimately, it's all about tick bite prevention. There's a lot of good information online about how to do it, but it's often quite wordy. I like to split it up into 4 stages. Shield, scan, scrub, and scan again. Shield. Know how to remove ticks. Wear long sleeves, long trousers, and light-coloured clothing. Acts as a barrier to the ticks attaching themselves to you, and if they do, it's easier to spot with light-coloured clothing. Tuck your trousers into your socks. You don't want them crawling up your legs. Use insect repellent. Stick to the path. Avoid brushing against long grass and bracken. Scan. Check for ticks while you're outdoors, and again thoroughly when you're indoors. Check all areas, including hair and areas that were previously covered. And if you do find a tick, remove it safely. Scrub. Wash yourself and wash your clothes. Studies indicate it needs to be a minimum of 55 degrees to kill ticks. And again, scan again for ticks in the following days in case you might have missed some, and in the following weeks and months for any unusual rashes. And ticks, they can get embedded into the skin. This is a picture of the tip of a pencil, and that's a little embedded tick. They like to get right in there. In terms of removal, it's beyond the remit of this talk, but there's some really good resources online. You need to use appropriate tools and use appropriate methods. You don't want to leave mouth parts stuck in the skin, and you don't want ticks to regurgitate the contents of their stomach into you. When they fed, they get to about 120 times their size. You don't want that back inside you. Increases the risk of disease. Be mindful of the risk of disparity. Yeah. And one aspect is skin colour. There's evidence from a couple of papers in the States that patients with melanated skin tones are more likely to have disseminated disease than their white counterparts. There's a number of thoughts as to why, but one of them is that the rash simply isn't recognised in their skin tones. It's not suspected. In these patients, there's this thought that it's more likely to affect white people. Now, there isn't any reason why a tick would prefer to bite a white person compared to any other skin tone. They're totally equal opportunity. They'll bite whoever comes their way. So just be mindful of the possibility. For some reason, there's a fair bit of prejudice and stigma around this infection and the patients who suffer from this infection. Be mindful that it exists and support your patients. There's issues with lack of knowledge, both in the public health sphere with regard to having an awareness that there are ticks and some of them are infected and there's risks associated with tick bites and being informed on how to prevent tick bites, but also in the healthcare space in identifying Lyme disease and knowing how to treat it appropriately. After this talk, you might find that you're a bit more aware compared to your colleagues, including your secondary care colleagues, and you might need to specifically point out the existence of the NICE guidance to them. And then the other aspect is the lack of first principles approach to diagnosis. A lot of what we do is pattern recognition, but there are times when the patterns don't fit, and that's when we need to welcome our inner Sherlock Holmes, get our problem-solving ability out there and just really piece together what's going on. So, general conclusions. There needs to be a general increase in awareness amongst the population of ticks and how to manage the risk around that. And the countryside is great. We just need to be informed about how to use it and maintaining our safety. Lyme disease or borreliosis can present throughout the year. History, and clinical suspicion is key. Erythema migrans is diagnostic, but its absence does not rule out disease. A negative test does not rule out infection. Check the guidelines for the dose and duration of antibiotics. And disseminated disease can present weeks, months, or years after the initial infected bite. In terms of resources for patients, Lyme Disease UK has some good information, as does Lyme Disease Action and the Lyme Resource Centre. The RCGP Lyme Disease Toolkit is very good. Resources for doctors, I'll point you towards the RCGP Toolkit. There's an e-learning module. There is a podcast. The Lyme Resource Centre has some very nice GP training. There's also the nice guidance. And like I mentioned previously, Dr. Neil Spector has given some really interesting talks while he was alive on Lyme disease and the research side of things. References, there are many references. And ultimately, thank you very much for listening, and I hope this talk has given you the tools that you need to go forward. Thank you.